Okay, today we are going to discuss adrenal imaging. First, we are going to discuss the normal adrenal anatomy. Adrenal glands are bilateral and they are located above the kidneys, and they have two major components. They contain peripherally the adrenal cortex, and centrally is the adrenal medulla. The adrenal glands appear to be pyramidal in shape, and on imaging they have inverted Y-shaped appearance on both sides. Normally, each gland could have a length of about 2 to 5 centimeter, and the thickness of each limb shouldn't exceed 6 to 10 millimeter. This is example axial CT image for the adrenal glands, shows the normal inverted Y-shaped appearance of the adrenals, and this is the coronal reconstructed images showing again the inverted Y-shaped appearance of the adrenal glands. Adrenal images including CT, MRI, and PET-CT. The CT is considered the gold standard for adrenal imaging because it is cost effective and it is help in diagnosis of many of the adrenal lesions. MRI is just preserved for problem solving issues if CT is non-conclusive or non-completely diagnostic. And PET-CT is reserved for just suspicious for malignant adrenal masses. And we have two types of PET-CT, either the routine fluorine FDG PET-CT or the advanced gallium dotatate PET-CT, and we are going to discuss this later. Abnormalities of the adrenal gland include primary neoplasm, or metastatic adrenal masses, or adrenal hemorrhage, or either the enlargement of the adrenal glands from exogenous hormonal effect. Adrenal masses could be hyperfunctioning or non-functioning. Hyperfunctioning adrenal masses could include pheochromocytoma, aldosteronomas, or cortisol or androgen producing tumors, and of course they are presented with multiple clinical scenarios according to which type of hormone is secreted from these tumors. Non-functioning tumors including most of the adrenal adenomas and also the metastases. These are presented either accidentally, as in case of the adenomas, or in the metastatic workup in the patients with known primary tumor. The CT protocol for adrenal imaging is a dedicated protocol. We should include a dedicated protocol for the adrenal gland for proper characterization of adrenal mass. First, we perform the unenhanced CT study, and we look for two issues. First, we look for the size, and second, we look for the CT density in this unenhanced CT. If the CT density is below 0 with the negative Hounsfield unit, then we are confident then this is a benign adrenal lesion, and it could represent just adrenal adenoma or adrenal myelolipoma if we are just measuring the adrenal fat. And as regard the size, if we have a cutoff value of 4 centimeter, above 4 centimeter is suspicious for malignant adrenal mass, and if it is below 4 centimeter, then we are considering a more benign adrenal lesion. After we perform the non-contrast CT, and after looking for the CT density particularly, we consider to perform completion of the study after IV contrast, or we just terminate the study if we have Hounsfield unit below 0. And if we have Hounsfield unit from 0 to 10 or above 10 Hounsfield units, then contrast enhanced CT is required. Contrast enhanced CT should be performed in two phases. First, we perform the portovenous phase, which is included after 60 to 80 seconds after injection, and also delayed images from 10 to 15 minutes from the injection. And these are the crucial timing for performing the adrenal protocol for a particular characterization of adrenal mass. The enhanced CT is used, the contrast enhancement is used to formulate what is called the enhancement washout formula, to identify if there is absolute washout or relative washout. What is this formula? It is easy, and you don't need to revise all this formulation and the substitution. It is applicable on online calculator for the CT contrast washout. These are the house field unit you will be performing the measurements on your machine. The ROI performed on the adrenal gland should be as much as larger as you can, but not touching the adjacent adrenal tissue. The house field units are performed, and then the absolute or relative washout will be calculated. What is meant by absolute washout? Absolute washout, it means that there is rapid contrast uptake followed by rapid washout, and this is particular for benign adrenal masses. If the absolute washout is 50 or 60 or more, then this is a benign adrenal mass, and this is characteristic for adrenal adenomas. But if the relative washout is below than 50, then this is indeterminate, and it needs further characterization either by MRI or could be by biopsy. In the unenhanced CT lipid-rich adenoma, if the house field unit is 10 or less, it is diagnostic, and we could terminate the study at this level because it is lipid-rich and this is an adenoma, and we don't need to perform the further contrast injection. But what if it is a lipid-poor adenoma and the threshold value on the non-contrast CT was more than 10? Then we can't differentiate if it is a lipid-poor adenoma or it is a malignant adrenal mass, and then again furtherly confirm it by the contrast enhanced CT in the portovenous and delayed images. Adrenal adenoma mostly are lipid rich, and we are lucky to have these lipid rich most adrenal adenomas, but some of them are lipid poor, as we mentioned earlier. Lipid rich adenoma is characterized by predominant fat content, and as we mentioned earlier, it has a low ADC, low house field unit on the non-contrast CT, and if we perform the contrast enhanced CT, it will have absolute washout more than 60%, and this is characteristic and diagnostic for adrenal adenoma. So if we have renal mass, if it is more than 10 or it is less than 10 house field unit, if it has washout more than 60 or less than 60, if it is less than 10, then we can deal with a definite lipid-rich adenoma. And if it is having washout, absolute washout more than 60, then it is a lipid-poor adenoma, and this is characteristic. But if we have a lesion that has absolute washout less than 60%, then we are dealing with an indeterminate lesion. Let's see what lipid-rich adenoma looks like on the CT. This is a small left adrenal mass. It shows hypodensity in this CT study. It could be like this, appear as if it looks like a cystic structure. And this on the portovenous image, it has some enhancement, and this makes it not just adrenal cyst. Let's check this example for assessing the house field unit and the calculator of the washout. This is a left suprarenal mass. It has a non-contrast CT house field unit of 32. And after contrast, the house field unit become 149, and the delayed images shows house field unit of 61. We use the calculator, online calculator. We don't bother ourselves by this mathematic issue. We use just the online calculator, and we get absolute washout of 75%. So let's check with ourselves. This has absolute washout more than 75%. Then this is adrenal adenoma, and it is the lipid poor adenoma because it has a high house field unit on the non-contrast CT, and as such we excluded completely the metastatic adrenal masses. Let's go for MRI. How can we assess the suprarenal masses on MRI? Adrenal adenomas appear to be of homogeneous T2 weighted image, and it appear to be having intermediate to low signal, and this signal should be similar or comparable to the adjacent muscles or the adjacent liver. This is how it looks like on the T2 weighted image. Actually, we don't rely on T2 weighted image for characterization of adrenal adenomas. It is just preserved for Pheochromocytoma, as we will mention later. The money image in MRI for characterization of adrenal adenomas is the chemical shift sequence, which is known as T1 in and out phase image. And this is the money image MRI in characterization of indeterminate adrenal masses to differentiate between adenomas and malignant adrenal lesion. The enhancement kinetics in the MRI, it is the same as the CT. It has rapid contrast enhancement and rapid washout with, again, the calculations for the enhancement criteria, and we will check it later. Let's know what is known by the T1 chemical shift images. The T1 chemical shift image is assessing the tissue in a pixel by pixel. Every pixel could contain water only, or it could contain fat only. And also some pixels contain mixed fat and water. So when we look for the in phase, the signal from the water and fat are additive together, and they are added together. But in the out of phase image, they are nulling each other, and so we see that the intracellular fat, which is located within the adjacent water locules, are dropped, and it will give us a characteristic appearance on MRI. How can we formulate this T1 chemical shift into a real imaging? We define tissues as tissues with bulk of fat, or water tissue, or tissues with intracellular fat. If we have a bulk of fat, like the subcutaneous fat or angiomyolipomas in the kidneys, the tissue in the T1 weighted image appear to be of a bright signal. And on the out of phase image, it doesn't drop its signal because it contains only fat, no water content in this tissue. The water will be just at the interface, and it will be dropped, giving the chemical shift artifact or the India ink sign surrounding the bulk of fat. This is example for left renal mass. This is a fatty lesion containing high signal on the in phase image, and on the out of phase image, the lesion doesn't show significant drop the signal. The dropped signal is just at the periphery of the lesion, at the interface between the tissue and the adjacent peritoneum, and also between the fatty tissue and the adjacent renal tissue. This is the India ink sign, and this how looks like the bulk of fat on in and out of phase. No dropped signal occurs on the out of phase image. What about water? If we have a simple cyst, renal, or any tissue that contains just fluid content like renal cyst, the signal appears the same on in phase and out of phase. And as we are dealing with a T1 weighted image, it looks dark on the in phase, and also it looks dark on the out of phase image. What about the intracellular fat, where the tissue contains both fat and water? There is a dramatic change occurring in the in and out of phase image. In the in phase, the tissue is the intermediate signal, and it completely dropped the signal on the out of phase image, and this is a clue for diagnostic intracellular fat. And this is how it looks like for left suprarenal adenoma. The signal nulls or become darker on the out of phase image, and it indicates the presence of intracellular fat. So MRI, in addition to having this visual assessment, sometimes we can assess the dropped signal just visually. So we need, again, calculator to assess the change in the signal intensity. And we know these calculators as assessing the splenoadrenal ratio and the signal intensity index. For adrenal adenoma, the splenoadrenal ratio should be less than 70%. It is highly specific for adenoma. This is how the signal drops on the out of phase if we can't identify it visually, because sometimes the fat content is very minimal and we can't visualize this by our own eyes, and we need to have ROIs and measure the splenoadrenal ratio for assessing the adrenal adenoma. As regards the signal intensity index, if it is showing less than 5% change between the in and out of phase, then it is 100% characteristic for adenoma. How can we see the lipid-rich adenoma on the MRI? Again, this is the previously seen example. This is the in phase. It shows intermediate signal on the T1 weighted image, and on the out of phase, there is complete drop. The signal is noted, and the mass become dark on the out of phase image, and this is a characteristic for lipid-rich adenoma. We don't need to perform the calculations by ourselves. There is Adrenal MRI Calculator, and it is available freely online. You just put the signal intensity of the adrenal mass on the in phase, the spleen in phase signal, the adrenal signal on the out of phase, and the spleen out of phase image, and then you click just calculate, and it is automatically giving you the adrenal to spleen ratio, and also the adrenal signal intensity index, and this help in characterization of adrenal adenomas. What about another disease which is known as adrenal hyperplasia? This is including enlargement of one or both of the adrenal glands. The enlargement include the lymphs, but preserving the normal morphological appearance of the adrenal with the inverted Y-shaped appearance. We said earlier that the maximum accepted thickness for the adrenal lymph is 10 millimeter in thickness, and if it is more than this 10 millimeter in thickness, then we are dealing with the adrenal hyperplasia. Adrenal hyperplasia shows profound accumulation of lipid content inside, and this lipid accumulation could be uniform, including the whole suprarenal gland, or nodular form like this on the right side. As long as it shows the high lipid content, again, it will be having similar imaging characteristic similar to the adenomas. On the in and out of phase image, it will show a remarkable drop the signal like here, and because we have a preserving normal configuration, then we are dealing with adrenal hyperplasia rather than adrenal adenomas. Adrenal hyperplasia on the FDG PET-CT appear to be showing the uptake of the tracer, and this is the avid uptake with the increased thickness of the adrenal on the corresponding CT images. What about functioning adenomas in a PET-CT? Functioning adenoma will uptake the contrast, and it shows FDG avid appearance on the PET-CT study. And if we see this, we just correlate again. We can't discriminate by this increased FDG avidity if this is a benign tumor or if this is a malignant adrenal mass. So we can't characterize depending on the FDG uptake, because the benign and the malignant adrenal lesions could have increased FDG uptake. And again, we rely on the anatomical imaging of the CT for further characterization if this is an adenoma or this is a suspicious mass lesion. This is a non-functioning adenoma, and as long as it is a non-functioning adenoma, it doesn't show increased FDG uptake, and it appears to be of low grade activity like appear here. The adrenal hemorrhage, it could happen occurring unilateral or bilateral. There are multiple causes for adrenal hemorrhage. The most important cause is the trauma, especially if it is unilateral, and also spontaneous adrenal hemorrhage could occur, but it is more common in pediatric age group. Adrenal hemorrhage also occur in tumors, in either benign or malignant tumors. It could have components with hemorrhagic changes inside. But what about bilateral adrenal hemorrhage? This indicates that this is a systemic disorder, especially from anticoagulant therapy. And these are examples for adrenal hemorrhage. The imaging features of adrenal hemorrhage depend on the stage of the hemorrhage. And on this MRI coronal image, the left suprarenal lesion appear to be significantly hyperintense, with a hypointense central portion, indicating mixed-aged blood products within this left adrenal gland with areas of subacute hemorrhagic changes, and this is characteristic for adrenal hemorrhage. But again, we can't rely on this image alone, because there are some areas that are not hyperintense, and it could happen as a hemorrhagic change in a mass, and then further characterization with the rest of the pulse sequences, and again the signal intensities could be helpful in such a setting, also with the clinical setting of the patient. This is a bilateral adrenal hemorrhage on the CT. If we are dealing with acute hemorrhage on the CT, then it appears as hyperdense lesions, and we can see the hyperdensity below 60 or 70 House-filled unit, and this is conclusive for adrenal hemorrhage on non-contrast CT. But sometimes the adrenal hemorrhage appear as hypo to iso-dense lesions on the CT, which could occur in more chronic adrenal hemorrhage, and this will be difficult in characterization, especially if bilateral, and we are going to discuss later the differential for bilateral adrenal masses. The myelolipoma, it is a benign adrenal tumor. The main cornerstone to diagnose myelolipoma is the presence of macroscopic fat. Macroscopic fat, we mean by macroscopic fat that this is a fat similar to the subcutaneous fatty tissue. Sometimes it contains other tissues, including hemorrhagic changes or other soft tissue organs, and this doesn't yield the diagnosis of myelolipoma. Usually it is asymptomatic, and usually it appears as intermediate to large masses. This is example for myelolipoma. This is right suprarenal mass, which contain a significant fatty changes. With these significant fatty changes are also seen on the axial image. If you are not looking for this fatty lesion, you could miss it easily with the retroperitoneal fat. But here on the coronal reconstruction, we can see the indentation of the adjacent hepatic parenchyma, and this is diagnostic for myelolipoma due to the macroscopic fat. Another example for myelolipoma, which has a mixture of fat and soft tissue component like this, and if we see just this fatty component, then we are dealing with confidently a myelolipoma. On the MRI, the myelolipoma have the same characteristic of the fatty lesions. It could have macroscopic fat like this portion, where the periphery of the lesion is hyperintense on the in-phase image, and it doesn't show drop the signal on the out-of-phase image with the peripheral India ink sign, as we mentioned earlier. But on the T1 fat suppressed image, this peripheral component is showing a significant drop the signal, and this means that this is a macroscopic fat, and this is similar to the subcutaneous fat in all pulse sequence. On the T2 weighted image, you can misinterpret this lesion as a cystic lesion because it is appearing as a hyperintensity on this T2 weighted image. But if you perform T2 fat suppressed image, you can see the same suppression for the macroscopic component, and this excludes the presence of a cystic change. Myelolipoma can also have microscopic fat inside as this component, which appear to be of intermediate signal on the in-phase image. Then it shows remarkable drop the signal on the out-of-phase image, and this means that there is associated intracellular fat. This intracellular fat doesn't change on the fat suppressed image. It only appears on the chemical shift image. And on the T2, it again appears as intermediate signal for both lesions. And so T2 can't confidently characterize the myelolipoma. What about the metastasis? This is one of the commonest dilemma, especially if we have a patient with a primary known primary malignancy, and on the metastatic workup we discovered adrenal lesion. Is it a benign adrenal adenoma, or it is a metastasis from this primary tumor? The metastasis, it doesn't show any dropped signal on the MRI, T1 in and out of phase image, and it shows a heterogeneous appearance on CT and MRI image. The size of the metastasis is completely variable from small size to huge metastatic lesions. It could be unilateral or bilateral. And the most common primary for metastasis to the suprarenal gland is the bronchogenic carcinoma. Here is the in-phase and out-of-phase image for the left suprarenal mass. We can see that the signal is intermediate on the in-phase image, and the signal appears nearly stationary on the out-of-phase image. And notice the India ink sign at the periphery of the lesion. Then this means that there is no fat content inside this lesion, and this raises the possibility of a malignant left suprarenal mass, and in a setting of a known primary, this is considered metastatic till proved otherwise. On the PET-CT, adrenal metastases usually have significant FDG uptake, and these are two examples for two patients with small left adrenal metastasis showing avid FDG uptake, and this is a larger adrenal mass with also avid uptake. Adrenal cortical carcinoma, it is one of the malignant primary adrenal tumors. Usually at time of diagnosis, it appears as a huge mass, more than 6 centimeters. It could have some foci of calcifications. It has heterogeneous enhancement with hemorrhagic changes and necrosis. And the most characteristic sign for adrenal cortical carcinoma to be differentiated from other malignant adrenal masses is the venous invasion. The venous invasion is characteristic for adrenal cortical carcinoma, as we are going to see in the following slides. This is the non-contrast CT, and this is the portovenous CT. On the non-contrast CT, we see that the left suprarenal mass is large, and so if it is more than 4 centimeters, we exclude being adenoma. And there is also calcifications. Calcifications could happen in adrenal adenoma or in a previous hemorrhagic adrenal lesion. But after we see the contrast enhancement, there is enhancement, and this is suspicious for malignant left adrenal mass. This is a right adrenal mass lesion with infiltration of the adjacent IVC. The infiltration of the IVC is a characteristic, and if we see this sign, then we spot this as adrenal cortical carcinoma. Another example on the MRI, this is a huge right suprarenal mass lesion with infiltration of the IVC. We can see that the tumor is protruding into the IVC lumen. Another example of the left suprarenal mass with infiltration of the IVC, again via the renal vein. There is infiltration of the IVC. This mass shows a heterogeneous enhancement on the early arterial phase, and on the portovenous phase there is infiltration of the IVC, and this is the coronal reconstruction with true tumoral extension into the IVC, and this is characteristic for adrenal cortical carcinoma. What about adrenal lymphoma? It could happen as a part of non-Hodgkin lymphoma, as a secondary lymphoma. It rarely occurring as a primary adrenal lymphomas. It implicates the whole adrenal gland with the diffuse enlargement of the adrenal glands could be seen bilaterally, with significant FDG uptake as the rest of the lymphomatous deposits, which are very avid on the PET-CT. Adrenal cortical carcinoma, again with the heterogeneous enhancement and the increased PET uptake on the PET-CT. But PET-CT is not to characterize that this is adrenal cortical carcinoma. It is very important to identify its metastatic changes, especially the presence of regional metastatic lymph nodes, which is important for therapeutic planning. Pheochromocytoma, it is one of the neuroendocrinal tumor, and as long as it is one of the neuroendocrinal tumor, it has a characteristic somatostatin receptor, and we can use this criteria for our imaging, as we will say in a while. The diagnosis of the pheochromocytoma is by the 24-vinyl mandelic acid and metanephrine in the urine, and these are characteristic for pheochromocytoma if they are elevated. Pheochromocytomas are usually benign and usually unilateral, but it has the rule of 10. Let's remember the number of the rule of 10 for the pheochromocytoma. 10% of the pheochromocytoma are bilateral, 10% are extra-adrenal, 10% occur in children, and 10% are malignant. And we mean by malignant pheochromocytoma that these are metastatic to the liver, bone, lung, and etc. Also, pheochromocytoma is presented by hormonal disturbance because it is a functioning adrenal mass, as we mentioned earlier, and the patient could present with hypertensive crisis, hypertension not responding to treatment, or headache sometimes. The pheochromocytoma could have multiple associations, especially with men syndrome, von Hippel-Lindau syndrome, and also neurofibromatosis. So if we have a diagnosis of pheochromocytoma, we should search for men syndrome and also exclude von Hippel-Lindau and neurofibromatosis. The CT characteristic appearance for pheochromocytoma, it appears as a large lesion, more than 3 centimeters. It is usually heterogeneous, areas of calcification, areas of hemorrhagic change, and the most important sign is the significant enhancement and the significant washout. Again, this is particular enhancement criteria is very similar to adrenal adenomas. So if we have a mass lesion that is about 3 centimeters, it is sometimes difficult to differentiate between pheochromocytoma and lipid poor adenomas because of the enhancement kinetics of both lesions, which are similar. So the criteria for absolute washout and relative washout is not diagnostic in such a scenario, and we should rely on MRI for better characterization of these masses. MRI is very helpful in characterization of pheochromocytoma because usually the mass appears as a hyper-intense signal on the T2 weighted image. And this is unique for pheochromocytoma, and it rarely occurs in other adrenal masses. As regards the extra-adrenal paragangliomas, we could search for the pheochromocytomas in retroperitoneum, and it could occur all through the course till the organ of the Zucker candle, which is located at the level of the inferior mesenteric artery or the bladder dome. So if we have a clinical suspicion for pheochromocytoma, search first for the adrenal masses. If you don't see any adrenal mass, then search for the extra-adrenal paraganglioma, which is another type of the pheochromocytoma, and this search should include till the level of the inferior mesenteric artery and the bladder dome. On the PET-CT, pheochromocytoma appear to be avid, but not all pheochromocytomas appear avid. As we mentioned earlier, most pheochromocytomas are benign tumor, and the benign tumors are more or less show low FDG avidity on the PET-CT. But if we see that the adrenal mass is significantly avid on the PET-CT, then we are suspecting that we are dealing with malignant pheochromocytoma rather than benign pheochromocytoma. Then comes the recent imaging tool, which is the gallium dotatate PET-CT. Gallium dotatate PET-CT is characterized for the neuroendocrinal tumors with somatostatin receptor. It is targeted for this particular set of tumors, not for all tumors, and it doesn't depend on the metabolic activity of the tumor. It just rely on the presence of the somatostatin receptors on the cells of this tumor. It is very sensitive to assess the the pheochromocytomas and paragangliomas, not only the primary tumor, but also its metastasis against to the background contrast compared to the FDG PET. So if we are dealing with a benign paraganglioma or pheochromocytoma, then gallium dotatate is the first investigation of a choice, should be performed for characterization and localization of the metastatic disease. Gallium dotatate have a pitfall that normal adrenals show physiologic uptake. We see here normal appearing adrenal glands bilaterally, but they are showing physiologic uptake on the gallium dotatate because they are normally having somatostatin receptors. So don't misinterpret this uptake as a pathological uptake, and you should compare this uptake to the enclosed CT component of the PET to identify if the adrenals are normal or there are underlying masses. This is an example for right-sided pheochromocytoma with increased gallium dotatate uptake noted here, and note that the left suprarenal gland is also showing increased uptake, but if we refer to the morphologic CT assessment, then this is a physiologic uptake and the pathology is only located within the right suprarenal gland. Sometimes adrenal adenoma could be misinterpreted on the routine imaging as paragangliomas, and if we perform the gallium dotatate PET-CT, then will be negative because they are not paraganglioma and they are showing no FDG uptake. Sometimes the gallium dotatate shows false positive results, especially if we are dealing with a necrotic hemorrhagic pheochromocytoma. It could happen to occur that the mass lost its somatostatin receptors with no gallium dotatate uptake, and this means that we are dealing with a malignant pheochromocytoma, and it will be betterly appreciated on the FDG PET rather than the gallium dotatate PET. And so this indicates the not only the diagnosis of the paragangliomas, but also it gives us an interpretation of its histopathologic and metabolic activity of this tumor. To sum up the bilateral adrenal masses, it could include neoplasm, and the most important neoplasm that could occur bilateral is metastasis or lymphoma. And we should search for, if we see bilateral adrenal masses, we should search for a primary, and if we didn't find any primary, then raise the possibility of lymphoma, especially if there are other nodal involvement. Pheochromocytoma could occur bilateral in 10% of the population, as we mentioned earlier. Less commonly, adrenal cortical carcinoma, neuroblastoma, which is a pediatric adrenal tumor, and also the ganglioblastoma. Sometimes benign neoplasms like adrenal adenomas or adrenal hyperplasia, especially of the nodular type, it could occur bilateral, as we mentioned earlier. Bilateral adrenal lesions could include infection, especially the tuberculosis and histoplasmosis. Sometimes parasitic cysts can occur, and we have seen just one case of adrenal hydatid cyst. And also bilateral adrenal masses could have bilateral adrenal lesions could include adrenal hemorrhage or pseudocyst, or it could occur in autoimmune disease, which is Addison disease, where there is atrophic bilateral adrenal glands. So this is a flow chart how to deal with a bilateral adrenal mass. let's ask ourselves, is it is focal or it is a diffuse? If it is diffuse, if the affection is atrophic or hyperplastic adrenal tissue. If it is atrophic, then it is an easy diagnosis. This is an Addison disease. But if it is hypertrophic, then we are dealing with hyperplasia, adrenal hyperplasia. What about focal bilateral adrenal masses? If it has fat-containing appearance, then we are dealing with myelolipoma. If it is a solid component, then we need a proper history to, especially hypertension, to exclude paragangliomas and pheochromocytoma. And then we refer to the wash-out dynamatics and the decalcification to classify metastases, lymphoma, pheochromocytoma, and infections. And lastly, this could occur as cystic lesions, and these are the differential of cystic lesions. Rarely we see a cyst, we just see cysts after hemorrhage, and this was resolving hemorrhagic changes from previous adrenal hemorrhage. Thank you.
Thank you very much, Dr.